Let your curiosity rise.
Matrix webcast,
Where the human spirit flies. Matrix webcast. Where the human spirit flies.
Hey, welcome to the MedBix webcast, live from Silicon Valley. This is a place where physics, mathematics, and engineering, technology, medicine, this is a meeting place. So, welcome to the MedBix webcast. It is hot today in Silicon Valley. Very rare sometimes, but it's hot. Once in a while, we get a hot weather. This is the hot weather. Let me, without a further delay, I am going to bring my tall, 6 foot tall woman, my co-host for a long time. It's Dr. Susan Davis, beautiful, blonde, and bold and brainy. Welcome, Susan. Are you 6 foot or almost 6 foot?
No, I'm 5'10".
5'10". Okay, good.
And listen, how hot can it possibly be?
You're not that threatening.
No, Romana, how hot can it possibly be in Silicon Valley for you to call it hot? How hot is it?
Maybe hey, today very hot, 96 degrees. It says
What? Wow.
Yeah.
Okay, that is pretty hot.
very hot today. So I didn't know that. It's a very rarely comes that kind of a hot today.
Yeah. Wow.
Yeah, we get like a 2-3 times a year, 96 and all those things. It's not a common. Thank you so much, Susan. We had a very long journey together, and
Yeah.
you became a co-host for a long time. Thank you so much for being an excellent co-host, and we are really making an impact.
You know what, Romana? It is a joy to be here and to meet these exceptional humans doing exceptional things on our planet. And tonight's guest is no different than the last many. Another amazing person doing amazing things with a rare specialty that people need to know about. So I'm thrilled for you to introduce her.
Well, without a delay, that you mentioned the guest of honor, and let me bring here the guest. Let me introduce her tonight. It is my great honor to introduce our distinguished guest, Dr. Toyosi. And I don't want to say one of my. Let her do the last name. It's worse than my last name. I think she doesn't mind. Dr. Toyosi is a board certified hematologist and associate professor with tenure at Duke University School of Medicine, one of the most respected medical institutions in the world. Duke is very, very well known. Dr. Toyosi specializes in some of the most complex and challenging blood disorders we face today: sickle cell disease, hemophilia, and rare clotting and breeding conditions. Do you remember that yesterday that I was talking about Charles Drew? He died because he has a rare clotting condition, actually.
I thought he was in a car crash.
He died in car crash, but the problem he encountered in the hospital is a rare blood clot. That's what they said. She has dedicated her career not only to treating patients, but to understanding why breakthrough therapies like a gene therapy and CRISPR-based medicine, including Casgevy, is succeeded or struggle in the real world. She advises biopharma and biotech leadership on how patients actually access these life-changing treatments. And she is pursuing an executive MBA at a Duke Pugba School, I think, of business, focused on health sector management, because she understands that great medicine alone is not enough. Access, policy, and systems must align for patients to benefit. Dr. Toyosi, welcome. Welcome, Dr. Toyosi. Now you can say your last name now.
Thank
Welcome.
you so much for having me. Susan, Romana, thank you. What a privilege it is to be here with you.
Actually, I don't want to say that, but my ex-wife's sister looks like you exactly. She's a professor now. She was a retired professor.
I hope you're still on good terms so that I look like you like.
That's a pay. That's a lottery, though. So let me, Dr. Toyosi, did I miss anything with your background? Or, you're associate professor in Duke University. That's a very good school. Everybody takes, in East Coast, one thing is very famous is everybody does Duke seventh grade. Every kid takes that seventh grade test or something, Duke test. And my son took it, and I think he got selected there. It's a very few people get selected for Duke seventh grade test. Seventh grade or fourth grade, I forgot completely. Something they do in seventh grade. But Duke is very well known for that kind of encouraging young kids to study and compete. Let me ask you a question. What is your journey? That where did you finish your MD, and then just give me where you were born, and how did you end up in Georgia and Duke and North Carolina?
Oh,
Take your
wow.
pick.
You're
Take
I
your pick.
know.
My question is,
tell you my life history. Well,
yeah.
I'm originally from Nigeria. I was born in Nigeria, and my parents were traveling parents. So my father was a diplomat, and we lived internationally. And along the way, I eventually came to start college in the United States, and that was my journey was starting college, and that's how I got to Macon, Georgia, where I went to Wesleyan College. And from Wesleyan, I went to Duke for medical school. And so there began my long journey at Duke. I did medical school at Duke. I did residency at Duke. And then I went to Northwestern in Chicago
Yeah, yeah.
for my fellowship in hematology and oncology. And I ultimately chose to specialize in hematology, which is blood disorders that have nothing to do with cancer. And I've been doing hematology ever since. I went back to Duke for my first faculty position and have stayed until now. And over the last few months, I've started getting my MBA because, as you mentioned, it really is about how do we make systems work to increase
Mm.
access to all these breakthrough therapies as they're coming on the line. So excited to talk with you and Susan today. Thanks for having me.
So, Ramana, I have to cut in really quick because I think, Dr. Toyosi, you made a really interesting separation of state and church from the hemonc. Hematology, oncology. People combine those, always combine them. And until I started reading your work, I really didn't think about hematology as its own. And then the more you read and the more I listened and read your work, man, oh, Shevitz, there's a lot to learn about hematology versus oncology, and related or not related. So I just have to tell you a quick story. I was training a new nurse in the trauma ER years ago, and she said, "Who is this Dr. Hemonc? I can't find him anywhere." They kept abbreviating Hemonc, and she thought it was, anyway, you get it. So tell us, does that happen often? I mean, you have now specialized in hematology. Does everybody think that they're paired? I think
Yes,
Oh,
including
yeah,
me.
absolutely. Yes. So, a great question. So, historically, hematology and oncology were one because most of the blood disorders that we addressed were cancerous. And there wasn't much historically that we could do when we had blood cancers. And over time, as innovations have occurred and as we've progressed, there's really been a significant demarcation in terms of how much we can do for patients who have terminal illnesses and blood cancers. And so, yes, there are actually, if you think about it, I'd like to say there are three separate fields. One is just blood disorders, just a focus on blood disorders without cancer. The other is a focus on blood disorders that are cancerous, so leukemia, and then and lymphomas, and then just solid tumors, so oncology in its purest form. So we would say medical oncology, and that refers to all the tumors like breast cancer and prostate cancer, colon cancer. And then we have the malignant hematology, and that's all the blood cancers, leukemia, lymphoma, myeloma. And then there's hematology. Historically, they called us benign hematology, though over time there's been a shift. Yes,
Oh
it's
my
not
God.
truly benign, but there's been a shift in thinking about, well, maybe it's classical or non-malignant. You'll hear different names, but that's really acutely focused on blood disorders that are not cancerous. So think hemophilia, sickle cell, thalassemia, bleeding, clotting, a lot of all these disorders mixed into one and mixed under one umbrella. And the thing is that many of them are rare blood disorders. The most common that you probably have heard of is iron deficiency. So we're the iron deficiency doctors. That's the most common disorder probably that we treat. But most of our disorders that we address are rare blood disorders.
Wonderful distinction. I mean, you just add a distinction within the distinctions, because I think even learning that there's a difference, I don't think that terminology wise, solid versus a liquid tumor. I'm like, he's like, liquid tumor, what the heck is that? Well, you just, itemize many of them. I know as we move on, Romano will have amazing questions, but my thoughts are, I'm wondering across all those distinctions, if some of the new treatments that are coming out, gene therapy, I know we're going to talk about it, are there crossovers? So as we learn more about what the gene therapies are that you're working with, and do they cross over into the heme? Do the hemes treatments cross over into the oncs as we move forward? So it'll be interesting.
Yeah, it's a great question. I'll tell you that currently, at least as of the last taking of them, our boards are still the same. The hematologists take the same boards. And our training really is under the same umbrella. So many of us who have training in hematology also have training in oncology and vice versa. One thing I ask people to do is just to ask your doctor, what is the area that you most specialize in? And most oncologists can do a lot of things in hematology. A lot of hematologists can do things in oncology. But over time, especially as we're growing in innovation and all these new medications and new therapies that are coming to the market, it is hard to keep up with all of the innovations. And so people tend to start to specialize in one area. And I think it's important for people to ask their doctor, okay, you're a hemonc doc, what do you specialize in? So that they know that they're getting, what they need for the disorder that they have.
Gosh, if we don't learn anything else this whole time, Romana, that question right there is something that everyone listening to this should know. That question right there, because hemonc is not.
Very good question, very good answer. Let me ask you about your primary disease thing is sickle cell anemia. I heard Dr. Robert Pearl was a former CEO of Kaiser Permanente. He writes a column, breakthrough, fixing American system breakthrough. One of the columns he mentioned, I was fascinated by that, how the sickle cell anemia came to existence because of the malaria in Africa. So the people developed a defensive mechanism for malaria that became a sickle cell anemia. Tell us a little bit about that. That's a great story that he told us. I was fascinated by that.
Absolutely. So sickle cell disease is one of the first genetic disorders to be identified. And the story dates back to, I think, 1940s or 50s, where a young student from Grenada had sickle cell crises. And one of the physicians took a look at his blood under the microscope and saw that there were broken forms of the red cells, or sickled cells, so sickled shaped cells. And that's where the disease was first identified and has been studied really over time. Now, yes, as you mentioned, sickle cell trait, which is having one copy of the sickle cell gene, is actually protective against malaria. Having two copies now becomes problematic, because what happens is that there is a change in the hemoglobin. That's the molecule that's really important for carrying oxygen around the body. And what happens is that red blood cells, that's if you ever cut yourself shaving, you see that your blood bleeds red. And it's because it's the red blood cell. And hemoglobin is the oxygen carrying component in the red cell. So that red blood cells deliver oxygen throughout the body. So when there's sickle cell, the red blood cells are not able to just bend and deform as easily to get to the tiniest parts of the body. Instead, they just are brittle and they break apart. And so instead of delivering oxygen to the tissue, they can't get there because they're so rigid. And then they block the way. And then when you have one red blood cell blocking the way, you're causing inflammation. And then beyond where the red blood cell was supposed to deliver oxygen, there's what we call ischemia. That means oxygen can't get there. And that's why you have these painful crises, because oxygen can't get to the tissues. And that leads to cell death. So bone is dying, tissue is dying. That's why it's so painful. So sickle cell is a disease that's well known by its painful crises. But in general, there's a lot of inflammation and damage to organs. And that's how we see a lot of the manifestations of sickle cell disease. So yes, historically, a protector against malaria when only one gene is inherited, but when two copies are inherited, it becomes problematic.
So in India, it flipped a little bit, right? They call thalassemia, or that is that the Indians don't have the sickle cell, but they have the thalassemia. That is a thalassemia. Did I say right that word?
Yes, thalassemia.
That was the in India. A lot of it is a prevalent in India. That kind of a disease, a rare the blood disorder. So it is a basically same manifestation of the sickle cell, right? That is in with the Indian and the Asian groups.
Really, really, really great question. Yeah, we call them, so the group we call hemoglobinopathies. It's long
Hmm.
term, meaning all the
Cool
red blood
word.
cell disorders that impact delivery of oxygen, that impact the hemoglobin. And so, so in thalassemia, we have a different problem, and in that we don't have we have a change in the way oxygen is it's still an oxygen delivery problem, and the red blood cells don't function optimally. So what happens is you have all these red blood cells, but the body is not really able to make use of them. And so you kind of kick into overdrive trying to make more and more red blood cells, but it's what we call ineffective erythropoiesis. We can't make red blood cells very well. And so sometimes people with thalassemia have an opposite problem. With sickle cell, you have anemia because you keep destroying the red blood cells. They keep breaking apart. In thalassemia, you still can have anemia, but sometimes now you have excess iron in the system because you try to make red blood cells and you're not making them as well. So yeah, two separate diseases. Kind of they come from different backgrounds, but definitely kind of the similar presentation in terms of anemia, but not necessarily the same crises as you can see in sickle cell versus thalassemia.
So super interesting thinking about the three continents we just, discussed. I mean, we're here, we have, you're specializing right here, although from Nigeria here in the United States, India, with the thalassemia. I'm wondering how, and then Africa with the malaria story. So how early, do children, babies get diagnosed with these early? And then are the treatments that we have here in the United States the same treatments is it accessible globally accessible, these treatments? Because I think they're super expensive.
Wow, great question. I'll tell you that we've come a long way. And I think one of the most important changes that's happened first in the United States and is really rapidly multiplying around the world is early diagnosis. Early diagnosis is critical because if you can identify people early and you can start preventative therapies, then you decrease the risk of the organ damage that can multiply over time. Let's take, for example, sickle cell disease. Newborn screening in sickle cell disease was instituted really only a couple of decades ago, and that allowed people to identify children early and now start them on treatment early, so that over time the challenges that we can see with kidney dysfunction or heart trouble or lung problems that can come as a result of the repeated insults of sickle cell disease can be decreased. Now, when we started, we didn't have any therapies. One of the biggest breakthroughs very early on, especially for sickle cell disease, was identification of penicillin prophylaxis. So treatment with antibiotics preemptively. What happens in sickle cell disease from a very early age? So these are genetic disorders, so people are born with them. From a very early age, the red blood cells start kind of blocking the way in the spleen. And so the spleen, which is a very important organ for anti-infection, gets damaged. And so they're very prone to infection. And so early on, sickle cell disease actually used to be a disease of children because people didn't live till adulthood. And so identifying,
my God.
And so we've come such a long way. And so identifying penicillin prophylaxis or antibiotic prophylaxis allowed them to live into late childhood and eventually early childhood. And then another breakthrough that came along the way was the discovery of I'm sorry, I'm going to keep going. But you have a question for me.
The antibiotics. I just have to understand that the antibiotics were working at the spleen to help because they were breaking down.
The spleen is a really important organ, especially against certain types of infection. especially infections that are caused by bacteria that have a capsule around them. So we call them encapsulated organisms. So the spleen is really important to work against these kind of bacteria. So even in people today, if you had to take out your spleen, even if you don't have sickle cell disease, you first get immunizations against these particular bacteria because the spleen is so important in protection against these organisms. So yes,
Okay.
so
Thank you.
when the spleen is affected by the recurrent sickle crises, and then it stops functioning, then people become susceptible to the sepsis or the infections that can come
Gotcha.
from these bacteria. So that's
Okay.
why
Thank you.
antibiotic prophylaxis was such an early and important strategy in treatment. Okay, fast forward a few decades, and then we discovered that blood transfusions were so important, right? Once we were able to deliver blood transfusions safely and effectively, then we could take blood from someone who doesn't have sickle cell and give it to someone who has sickle cell, and then we're diluting out the sickled blood. And that means that there are fewer crises, but then there are also fewer complications. And what we noticed, blood therapy became really important in decreasing the risk of stroke as well. Okay, and we kept going, and then we finally figured out hydroxyurea, which was a chemotherapy drug, still a chemotherapy drug, that decreased the crises that patients had because it increased a specific type of hemoglobin called fetal hemoglobin. All right, and then we discovered a couple more medications, and now fast forward to 2023, where we finally had the approval of 2 gene therapies, and that's where we are in the landscape right now. So, in general, 3 potentially curative options. One is stem cell transplant, and so if you have a donor, if you have a matched sibling donor, you could get a transplant, and that's potentially curative. Or these new gene therapies. One of them is a gene addition. That means it adds normal hemoglobin. So then you have decreased effects of the sickle cell. And then the other is an editing, where it kind of edits out the abnormal sickle cell gene, and so that you can now have someone who presents as if they don't have sickle cell. Now, the
So
only thing I'll add,
FDA approved a Clagevy or whatever it is. That's a new drug approved
yes,
for the sickle cell
Casgevy
anemia, right?
and Lyfgenia. That's correct. That's correct. Both
Yeah.
FDA approved. And one of the things I talked about in my article, and you mentioned earlier, is that it's one thing to have breakthrough therapies approved. It's another thing for them to actually make it to the patients who need them. So that's the
It
biggest
is a
challenge
big
I
challenge.
think that we have right now is getting medicines to people who need them.
How expensive it is? This is in the United States and other countries. How expensive this could be?
What a great question. I'll preface it by telling you that I think the most expensive therapy is one that can't get to the people who need it. And so, yes, we talk about the price tag. So, $2 million, $3 million, that's a lot,
Oh,
for one therapy. But I'll tell you that, if we can't even get a life-saving therapy to individuals who need it, then it might as well cost $3 billion, right? So that's the biggest challenge. I think that people ask, why is it so expensive, and why can't it be cheaper? I think over time the medications probably get cheaper, right? If we think about across the board, when we first of all introduce a new therapy, and it's difficult to scale these therapies, they're very, very individualized. So essentially what happens is you collect the person's stem cells, you modify them, and then you reinfuse them after you've prepared the person with treatment. So it's a series of treatments. It's not just a therapy like I give you an infusion today and you're done. It's a series of treatments, including collection of the blood, processing of the blood, returning it to the patient, treating them beforehand. So it's a series of treatments, and it takes a lot to prepare the treatment for just one person. And these are people staying in the hospital for weeks to months. So it's
Wow.
a very involved treatment. It's a very involved treatment. So I think over time, as we continue to get better and we have more expertise at many more centers and more people are receiving therapies, I suspect costs will go down. But yes, people think of it as very expensive therapies. And I say, yes, but let's think of the greater expense of access to an innovative therapy that nobody can actually access.
So one of the a champion for the sickle cell anemia, that the drug and disease prevention, is a Dr. Ted Law, who lives here, and he contributed quite a bit in the sickle cell anemia. I don't know him. I was a friend of my friend, so just I want to mention him. He did enormous contributions here. Let me ask you the other side of the blood disorders. I was fascinated. This is first time I was reading about hemophilia. I There is a Bombay. It's a Bombay group. It's a Bombay disorder. There's so many blood groups. I didn't even get the blue blood. Some people have two different type of bloods in the types of blood in their body. Tell us a little bit of this variations. It's fascinating to us.
All right, I think you're talking about blood group systems, and now we're kind of coming to the transfusion side of things. So the reason we think about blood group systems and how we're also different, but sometimes we don't think about the difference in terms of the blood until it's time for us to donate blood, right? The moment I say I'm going to donate blood to you, it becomes important to ask, well, what is happening at the surface of your red blood cells? What is your blood system? What is your blood type, right? Because it affects whether I can safely receive blood from you. And when we look at it, there are two major blood group systems that we use to determine who can safely receive blood from another. But there are multiple blood group systems, and honestly, they're multiple. We won't go into all the details, but yes, it's the way that we are able to identify what's the safest blood group that we can give you, the blood type that we can give you, so that you can be safe when you receive the transfusion. Otherwise, you can have major reactions. Now, the most common, we think about A, B, and we think about A. Are you blood type A? Are you blood type B? Are you AB? Are you type O? We also talk about RH when it comes to like pregnancy, but then we also can go deeper and we start to talk about things like Kell and Duffy, because there are many blood group systems. So I don't know that I know what you're saying about blue blood. There is a disorder that it called methemoglobinemia, where people
Correct.
can have bluish tinge to their blood because of the disorder.
Yeah.
But yeah, so much about blood that's very fascinating and interesting.
I
Yeah.
I have a question for you. I heard this is very fascinating to me. There is a blood, the mother's blood can attack in the womb, the baby. That same blood attacks the baby. How do you, that's a very strange thing. How do you do that? And is it because the blood expression, like a protein, antigens, and all those things is involved? Just give us a little bit of a background on that one. That is fascinating to me.
Oh wow, this is so good. Okay, all right. We're getting really technical here.
No, no, I don't need it that much technical, but
Yeah.
it's a very fascinating to know that mother's blood attacking the baby at her own womb,
Good.
attacking it is a
Yes.
very strange.
So it has to do with what's the blood type coming from the father versus the blood type coming from the mom, and what does the
Mhm.
baby have as well. And especially for moms who've had prior children, they may be sensitized towards proteins on the surface of the baby's red blood cells. And so, yes, they can, these antibodies, if the mother has developed antibodies against a previous pregnancy, they can cross the placenta. And depending on the blood type of mom and dad, if the baby inherits a different blood type, for example, if they're O, then they can cross the placenta and it can cause problems. So yes, it has to do with the inheritance from mom or dad, and what the baby ultimately has, and if the mom has been sensitized beforehand through a prior pregnancy. And so yeah, it's a big deal
You
in
can
terms
cure
of
that, right? You have a cure for that, right? You can treat
sometimes
that condition.
sometimes what we do is we transfuse the baby in utero, because what happens is the baby ends up it's attacking the baby's red blood cells, so it's giving the baby anemia, and so sometimes transfusion is needed. We also do give a medicine to the mother to distract the immune system, so that there is a decrease in that crossover over the placenta. So yes, yes.
Very well described. I got to tell you, that's not an easy concept. You know, it's not easy to just blood types. Period are tricky. AB, ABO, I mean, blah blah blah. All those put together. The universal donor. What can we get? You know, they're doing a lot of. We talked about this a little bit last night about what they're doing in EMS with blood products in the field across the country right now. It's a fascinating, whole new wild west in blood products out in the field that are saving lives. I'll tell you something. This brought up a story. I know with my background is in trauma, nursing. It's been a long time now, but I remember taking care of many patients that needed transfusions from one reason or another. But one thing that was very interesting was the more transfusions a patient got, which maybe with these new gene therapies, that will less and less, right? Because you said it's perhaps curative, some of the new gene therapies. But for those who don't get them, they're still going to be getting transfusions. And every time you get a transfusion, it makes it a little trickier to get the next transfusion because you have to type and cross. And now you've had 2 or 3 or 4 or 5 or 6 different bloods in your body, and it takes longer to type and cross. Is it, I can imagine what it is like in the lab trying to do that. It's got to be,
Yeah.
there's a lot of components.
Yeah, really great question. Yes, it gets to a lot of technicalities, but essentially, it's like you mentioned. When we're thinking about transfusion, we do what we call a type and screen first to say, well, what type are you, and are there any antibodies that show up? That means, are there any proteins that are showing up that might attack proteins in that it might attack the red blood cells you're about to receive? So we do that. And then we do what's called a type and cross match, meaning that we're saying, okay, let's match your blood type to the blood type of the blood we're about to give you and make sure that there's no problem. Now, usually we match the blood at a very high level, but there's some what we call minor antigens that might be significant. And the more transfusions you receive, the more it becomes important. So, for example, we were talking about sickle cell earlier. Sickle cell patients with sickle cell get a lot of transfusions, and so they get something we call alloimmunization, and it means that over time they are exposed to these otherwise minor blood group antigens or proteins that they become sensitized to. And so the next time they receive the blood, even though it's exactly the right type for them, it's the right A or B, positive, it's not the right type for them because they have these smaller antigens that are showing up and recognizing the transfused blood as foreign. So yes, there can be many complications of that, including what we call a hyperhemolytic crisis. And that just means the body says, wait a minute, what is this? And destroys all the red cells and then says, well, I'm not done destroying. I'm going to destroy more of the red blood cells in the body. And then the person ends up in a worse state than they were before the transfusion, because now there's the destruction of not just the red blood cells that the body didn't like, but then the body turned around and destroyed its own red blood cells as well. So yeah, it can be quite complicated, which is why in patients who receive multiple transfusions, especially in patients with sickle cell, we say it's useful for them to get what we call extended matching. That's when we look beyond just ABO and RH to start looking at C and KEL and E. So making sure that we're identifying blood group antigens beyond the major ones.
Excellent explanation. Ramona, I'll just wrap that questioning up just to say that as a nurse, when you go to give a blood product, let's just say even it's just much less trauma because we don't know much about the patient, but a patient like you one just described, I can't explain to you the level of critical thinking that you need to be on your toes as the person administering these products. Physicians order the products, nurses give the products. And there's so many safety checkpoints involved when you're giving blood products to a patient. And, nurses have a second signer. You can't do it by yourself. A couple people have to sign off before you give them. I just love to bring awareness to how tricky it is to put another human's blood, no matter how much it's been matched, into another human, because something can happen, Ramona, in the first very few moments. As soon as something goes in a human's body, it's either in for the win or down for the count. Sometimes it's pretty scary.
So Dr. Toyosi, we have a standard. I'm from Silicon Valley. I wanted to introduce kind of concepts for doctors, engineering, technology, mathematics, and physics, those kind of things, and the other way around. That physicians, the healthcare entrepreneurs introduce a little bit of medical field. That is my goal, to interdisciplinary thinking. So I'm going to present a topic. You are probably teaching English. What I'm saying was, this topic that I'm going to present is probably teaching English, Professor English. That's your backyard. CRISPR. I'm going to talk about it.
Oh,
Let me.
excellent.
Navya, can you put that? Yeah, this is a, this is a simple, I'm going to tell you, you can jump in anytime, Dr. Toyosi. You know that this is actually the CRISPR. They actually started with the yogurt. We eat daily, everyday yogurt. I will take you to the journey of a yogurt war, how it turned out to be the scientific revolution in medicine in 21st this century. That is the, it started with the yogurt, actually. That is the history I'm going to talk about a little bit. This is a very strange. I was with my, that's my daughter, and me. We went. I was driving from Vanderbilt to Atlanta one day, after seeing my other son, who was attending Vanderbilt at the time. So I got a call from a Alabama country music star. I tell you, I'm Indian. I'm very, very far away from country music, country steaks. All of them are not in my blood. So I got a call from this gentleman. He is a part of the Alabama group, Ted Gentry. He asked me to come to his ranch. So my friend, another friend, introduced me to him on the while I'm traveling. So I said that okay, I'm is on the way. I wanted to drop by in Fort Payne, Alabama. So I dropped by at his ranch. He thought that everybody said that I'm kind of getting popular there in Atlanta area. Said that somebody told me that you're very smart and you can guide me. How do I change the gene modification for my cows? He wants to produce a better milk or a better meat or whatever it is. He wants to do that. And I said that you got the wrong guy. And then we ended up talking about coffee because I'm a physicist, I'm not a biologist. So that was gene modification was the first time I heard about what he wants to do. Is a very fascinating thing to me. So what I did was, that was a story that I got into the interesting. Danisco is in Fort Payne or in my hometown in a village in India, the way they make yogurt is that they boil the milk and they put the culture from one of the neighbors and put it there, and it becomes a yogurt. Okay, so that is a yogurt that makes a yogurt. But there is a, in a massive scale, you cannot go to the knock the people's doors. So Danisco started the enzymes cultures that produces the cultures and supply to the industry, to make a yogurt. The problem with was they found a very interesting problem. Same culture, some of the yogurt went bad, some of the yogurt is turned out to be good. They couldn't understand. It was a mystery. It was a mystery because some of the yogurt, it turned out to be fine, same culture, but turned out to be good and turned out to be something that they want to find out. Denisco went on further research because they lose money, right? Money is the key. So what they did was, Philip Horvath, chief microbiologist at the Denisco, he was working on this one. He suspected that in the Denisco eventually bought by DuPont. By the way, that's what I would say DuPont. Back he found that bacteria is doing something strange. It is a pending of the viruses are bad dudes. They're the ones who spoil the yogurt. So he was doing the bacteria. He found out bacteria is doing something strange to these viruses. It is fending off the viruses. He couldn't understand the mechanism. That mystery was eventually solved by these two brilliant women. Emmanuel Charpentier, she is from the Max Planck Institute for Infection Biology from Germany. And then Jennifer Doudna, Jordan Doudna is from the University of California, Berkeley, right here. So both of them solved this discovery. This is a bombshell discovery it is. It's a, the reason was, is a bombshell is that what they didn't expect actually. What they found out is that the bacteria is learning, it's a learning process and doing depending the way it does a very strange way. What they found out that is bacteria is a, I'll give you an example of this, is a for technology people, it is not for doctors, but the technology people understand. This is an example, I give it to them. If there is a neighborhood missing Amazon packages, somebody is stealing them, so they complain to the things, and then the law enforcement come with a canine unit and find out who is stealing these Amazon packages, for example. So they find a suspect walking around, and they give him a warning. They put him in a database. Hey, what are you doing here in the neighborhood? You don't live here. So they give him a warning, and they give him a database. They do that. When the suspect shows up second time, that they know this guy is a troublemaker, and then they told him not to come down to this one, to this neighborhood. He came down, so they arrest him and they send a canine unit and then catch him and put him in jail. This is the this is a very similar analogy for the invention. What is the virus page virus comes in the bacteria is a bad dude. When it comes to the viral genome, that thing, what is a bacteria does is interesting thing it does. It strips this viral genome page. I'm not a biologist, Dr. Toyosi. You can correct me anything I do wrong. So it does and puts in a very interesting way. It spaces it out and puts the this the stripped viral gene into and the embeds in its DNA. It keeps the mugshot of that viral DNA inside the bacteria. So what is the advantage when the viral, it doesn't know whether it's a suspect is really causing the problem or not, but it causes the problem. Next time when the viral gene enters the one, it knows that this guy causes the problem, and it compares that, and they attack with a Cas9 scissors and attacks and cut it off. So it is a fascinating to me of cyber security wise how it stored that information of the viral gene, stripping the viral gene and putting in a different places is a nature taught us the cybersecurity before cybersecurity guys in Silicon Valley. So that is fascinating to me. That was called CRISPR, clustered regularly interspace, short palindromic repeat. It just put in the different places that genome, viral genome, it spread across, so nobody can come down and put together it. No way you cannot trick them. That is a CRISPR. What they found out is, hey, if the bacteria is doing the cut and paste, why can't we do ourselves? We can do the cut and paste to people like Dr. Toyosi can do that. And they can take the defective gene like a sickle cell anemia, and then you can this bacterial survival mechanism transformed into the engineering of the CRISPR cut and paste mechanism of saving the humanity's cure mechanism. That they found out, if the bacteria is doing the same thing, we can do the same thing. We can cut and paste. We can cut the defective DNA and then put the mRNA with RNA. We can change all those things and then correct the sickle cell anemia. That's kind of a thing. That is what we are talking with Dr. Toyosi today about, that the lot of genetic diseases you can eliminate from the CRISPR. Genetic diseases, cancer, drug resistance, malnutrition, all of them. There is in MIT, what they do is they tell the silkworm how to create this globe. It's scary. It's a scientific wonder. It is telling the worms how to control, how to do the things together for them. It is very strange. It's scary a little bit because we are telling the microorganisms how to behave. It's a very fascinating thing to me. So it can clean up oil spills and protect endangered species, reconstruct ancient diets. That's interesting. Ancient diets you can reconstruct, with the CRISPR. So the other one, Clogevy is the sickle cell anemia. That's what FDA approved, actually, as you all know. But this is the technology side. I'm going to tell you. Computer storage, you can do in the flash drive. You can do 10 movies maybe, and then it will degrade through the magnetism. It degrades over the time. In 10 years, it's gone. So in DNA storage, you can put a one bacteria, you can put 1 million movies. Can you believe that? It's a thousands of years. The DNA, the bacteria divides. It can stay for thousands of years, no limits. Crazy stuff. But they did actually. They put the DNA storage. They put the bacteria. They put a movie inside. Washington University did that. Microsoft
Hmm.
funding. They did the movie in the DNA, a small movie. They put it there as a horse moving, running around. Actually, so 1 gram of DNA, you can put the entire DNA of the entire data of the world in 1 gram. See, think about that. How the CRISPR is turning into the. We don't need this data centers. We need to focus on this new CRISPR mechanism a little bit more and master the nature itself. Thank you for watching, and let me bring my guest there, and. Yeah. So did this is teaching the professor English, professor English. But he may not know about the technology that is progressing in the bacteria. They want to put a storage in bacteria. That's very interesting thing to me. Yeah, I'll let you.
Yeah, thank you for sharing that. I mean, I think a really, really simple way to think about it. And, someone was asking me a question today that now comes to mind where it's like, how much do you explain this to patients when they are asking questions about the therapies they want? And I find that, the background is important, but what people really are looking for is help making the decision. So the details matter, but more importantly, it's saying, let's talk about me, my disease, where I am right now, the damage that I
Yeah.
already have, the possibilities of this therapy, and whether it's worth going through all the process to try to get the cure, and will I actually be better at the end? And that's an important question, because sometimes people, I mean, what we do see is definitely pain crises decrease, but the chronic pain doesn't go away. And the lung disorder that's been affected by the sickle cell, the lung problem doesn't go away, the kidney problem doesn't go away. And so I think, it's also important to recognize that although all these therapies might now be available, the question is also, who is it for? Who's going to benefit the most from it? And making sure that people have those conversations to really understand what potential benefit they might get.
Just you mentioned communication is important. How do you say convey that? That's the story that I want to tell. That is a story that the MedBricks webcast does. That's a story we want to tell to the public. Hey, this is like a Cas9, like a canine. The Amazon. They tell the story, that kind of thing. People get understand, because CRISPR is very hard to explain. I struggled myself with the CRISPR. Is Everybody asks me, how do you explain that? It is a very, very difficult to explain. But now I was thinking about that, and came back with the analogies, so to people, regular people can understand it.
Yeah,
Absolutely.
I
And
think.
it's very important. And thank you for doing that.
Yeah, no, I was going to say at the very beginning of our show, you mentioned, Dr. Toyosi, the couple different versions. And the CRISPR, just for clarification, was the gene editing option. There was another, the
Yes,
gene addition option. And
correct.
so the beginning of the conversation, when we were talking about that, I was thinking, Romana, you just give a wonderful presentation simplifying such a tricky concept for patients or potential patients or family members or caregivers. But I'm guessing that the awareness needs to spread to physicians. The physicians around the country and across the world are, how well aware are they? And it's so hard. There's so much noise with AI right now. There's so much going on. Is there awareness for physicians to offer these things, even if they are $80 zillion to their patients?
Yeah, what a great question. I think one of the things that you are alluding to is how well equipped we are in our healthcare system for
Yeah,
longitudinal care. The kind of experiences that people have where they have one relationship or at least a series of relationships that are consistent, so that there can be a big picture look at the patient and how they're doing over time. Fortunately or unfortunately, a lot of our patients get care in what we call a fragmented system. That means
yeah,
sometimes they're in this emergency department, and this other time they're here in urgent care, and they may be at a different hospital. And so sometimes if the care is crisis driven, then it's hard to get us into a situation where someone's sitting down and saying, okay, let's look at everything that's happening. Let's look at what may be the best series of therapies for you. Because, these gene therapies are very important, but they're not the only therapies. And the question is, it takes a while to get to the gene therapy. So how are we optimizing all the other therapies that you're supposed to be on? So
Mm.
I think that to a great extent there is awareness, but I think there's an opportunity now for people to be in a stable, what I'm saying is a medical home, where there's a provider who is looking out for your long-term interests, usually a primary care provider who may not be a hematologist, but for patients with rare blood disorders, working with a hematologist so that patients get access to the therapies they need. And more importantly, I think what you're alluding to is that they get the education they need early on. Because it's one thing to say, oh, this therapy is available. It's another thing to say, do I understand what I'm signing up for? Do I understand that I'm taking weeks, months off work to get this therapy? Can I afford to do that? Who's going to be here with me? How am I going to support the children at home if there are children at home? So it's a big, complex decision that really works well when there's a foundation of relationship to really say what's important to you, what are the high priorities, and what do we need to optimize in your life in this season right now. It's probably easier when people are much younger, to it's but even then it's a conversation with parents and saying, okay, if we're going to do this big therapy, are you ready to take time off work? Do you have the resources? Do you have the support? So it's so much bigger than just the therapy or even just the knowledge. It's also, are we equipped to help people make the right decisions as they
Dr.
embark on.
Toyosi, Toyosi, did we
Excellent.
learn anything from a COVID pandemic? Yeah, the blood types and the COVID, any relationship there? Are they going any kind of a research came out of that whole process?
I am not as familiar with the COVID blood type literature, so I don't know. I don't know that research.
I have a zero knowledge, so that's don't worry
Yeah,
about
that makes
it.
sense. So, yeah, same.
so
I
so
will tell you that what I think about a lot, or at least I thought about a lot when at the height of the COVID pandemic, was the blood clotting risk associated with
Yeah.
yeah.
having the infection, and many of the studies that were going on at the time to figure out how do we best protect people from developing a blood clot after they've had an acute infection. And so that I can talk about. But yes, I don't know about the blood type relationship, but certainly the blood clotting risk is there.
I presented a
And
topic yesterday, Dr. Charles Drew. He had a blood clotting problem. That's why he died when an accident in North Carolina, in fact. Dr. Charles Drew, he said that when they took him to hospital, that one of the problem he had was the blood clotting problem. I didn't know much about it, but interesting way, that's interesting, I thought.
Sure. I'd love to talk about that a little bit. Now, one of the
Yeah.
things we don't think about is how our blood clots until we have something like a nosebleed. And then we're wanting the blood to clot, right? We're holding it so that it can clot. So blood exists in a beautiful equilibrium of flowy blood, right? It's got to pass through the blood vessels to get to where it needs to be, but then also blood that clots as soon as it leaves the body. And there's a really nice balance in the system to allow blood to flow when it needs to and then clot it when it needs to. Some people have a mutation in their blood clotting proteins such that even if they wanted to stop bleeding, they can't. And that's a condition that we generally call hemophilia, but there are different types of hemophilia. So one of the more commonly known ones is hemophilia A, which is a deficiency that they're missing a certain blood clotting protein called factor 8. And that means that they want to form blood clots to stop bleeding, but they can't. And so sometimes, depending on how much of a deficiency they have, they can start bleeding spontaneously. And unless you have access to give them back what they're missing, they could bleed to death. Fortunately, where we are now, we've learned so much and there's so many therapies available. And in fact, gene therapy is also available in hemophilia now. Now we're able to really address bleeding on so many levels. But yes, the inability to form a blood clot so that you can't stop bleeding is certainly a problem that we've grappled with for generations.
And now add about 6 physicians because you're in an acute care setting and you came in with one thing, but now you're bleeding. Now they're trying to stop the bleeding, and now we need to, add some coags. Now wait a minute, hold that. Wait a minute, there's a hole in the pipe somewhere. We got to hold this. When do we start again? Can we start again? You have all these different physicians with specialties. You must have like a bat line. I mean, I'm sure they want like the bat
Yes,
phone.
that's me.
Are we doing this right? Are we doing this right?
It is a great question. So one of the things that you are alluding to, Susan, is that while there may be this rare blood disorder called hemophilia, it's rare. What is not so rare is people who are on blood thinners. That's pretty common. Whether they have
Yeah.
atrial fibrillation or they have a history of a prior blood clot, a lot of people are on blood thinners. And so if, for God forbid, they come in because they've been in a major accident and now they're bleeding, but they're on a blood thinner, so they can't easily stop, then you're asking the question, okay, how do I stop this? What medication do I give? What blood therapy potentially do I give so that we can stop the bleeding, but I don't want to give too much so I don't now cross over into blood clotting territory. So yes, those are the questions that I help with as a bleeding and clotting strategist. And most of the people I help are physicians who are making those decisions in real time. They're saying, I don't want to give too much of this product that could cause blood clotting, but this person is bleeding and I need help now. Another thing that comes up is when a surgeon is trying to take someone to the OR and they're saying, wait, do we keep the blood thinner going? How do we stop it? What's the safest way to do it? And it can be anxiety provoking because bleeding is a big deal. It can be life threatening. And so, that's my area of expertise. Absolutely.
I used to sell genetic testing for the company at the time. People who are on Plavix, in the Plavix in the blood thinners. I used to sell the genetic testing for those for a while. I did
Yes,
that.
yes.
Dr. Toyosi, it's wonderful to talk with you. We are coming to an end. Thank you so much. It's a truly an honor and privilege, and you shared so much. Which is this area is a totally new to me. I mean, I've been in the medical field. I'm not a doctor, but I'm in the medical field, and I know a little bit here and there and everything. But this area, I didn't know so much there. It is a wealth of information. It's a depth and unbelievable depth it has, and now you shed some light on it. Thank you so much for that thing.
It is my
Yep.
pleasure. Thank you so much for having me. I've enjoyed myself thoroughly. Thanks for
Thank
welcoming
you
me.
so very much. Thank you for helping us and really spelling out how complex hematology is. And I also am very appreciative of understanding the difference between heme and onc. And thank you for dispelling Dr. Hemonc. He doesn't really exist.
Thank you all. Thank you all. Good night. Thank you all.
Thank you.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it